the way to target, and I think
let's get to
yeah.
transcranial magnetic stimulation. I'm just going to say it for you.
Yeah.
Am I right?
Yeah.
Is that right?
Yeah, I think that's one way, and I think that's an exciting way. It's something that I'm getting into and have written a couple grants on now that I want to kind of make part of the research into kind of targeting a specific circuit and affecting a kind of set of symptoms and potentially a set of behaviors that amplify those symptoms.
Yeah. Now, the big thing is have you noted transcranial magnetic stimulation to change that hyperconnectivity or hypoconnectivity that you've noticed in the fMRI studies that we discussed previously?
Well, let me give you a big picture view first of
I
TMS.
love big picture. Picture's the best.
TMS is the abbreviation for transcranial magnetic stimulation. Essentially, it uses a technology that was designed sometime in the 80s where there is a coil that produces a magnetic field that passes through tissues or materials until it hits a conductive set of material and then creates an electric current in that material. And so if you're holding this magnetic TMS machine up to the brain in any particular location, it'll pass a magnetic field all the way through the hair, the scalp, the skull, until it hits brain tissue, which is conductive. It has neurons or cells there that will fire based on some magnetic current and thereby produce an electrical activity in the brain regions that are closest to the scalp area where this TMS coil is held. And so given that technology, the kind of experimental story of TMS has been to hold it to different parts of the brain that are thought to be mechanistically related to disorders like depression or obsessive compulsive disorder, and see if by holding it there and treating with certain patterns of stimulation over the course of a treatment cycle can actually affect the symptoms in those conditions. And it's become FDA approved for depression, and I think more recently for obsessive compulsive disorder. But as far as I know, nothing neurologic.
Right. But those FDA approvals are just based off of, hey, these are the brain regions that we generally think that are affected with depression or OCD. So we're going to hold the TMS machine to these areas of the brain, right? And then just clinically, do they get better? Do they not? There's no objective measure that's then looked at after TMS.
No, there is. So it's a good point.
But I'm saying in the context of like in the community when someone's getting treated by TMS, right?
Usually not. Some practices will look at kind of measures of EEG on the scalp or heart rate variability to indicate that an individual kind of needs a booster therapy or something like that by following them over time. But largely in the clinical setting, there's not a lot of objective data that's being monitored to indicate kind of a treatment response, but it's the symptom improvement. But in the research setting, there's a lot of data being collected before the TMS treatment and then during and after to kind of set up a sequence of tests to understand whether the TMS is mechanistically affecting brain regions or circuits involved in this condition and whether that correlates with the symptoms.
So how does that tie into fMRI?
Yeah, so let me kind of continue with that 30,000-foot view and say that when it started, TMS was really focused on brain regions,
right?
Thinking that if you could affect part of the decision-making network that's closest to the scalp, this kind of dorsolateral prefrontal cortex region, you may be able to affect an emotion regulation center of the brain and improve its function and improve the cognition and decision-making capacity of it, and thereby improve symptoms in depression. And I think it was always thought that that would improve some circuit, but only until recently have regions been targeted because they are a kind of distal surface level part of a deeper circuit. It's known that in a lot of these psychiatric conditions that the deeper parts of the brain, like the amygdala, are involved, and the nucleus accumbens in reward are involved in the mechanisms of psychopathology or the symptoms of psychiatric conditions. And so to get to them, because the TMS coil can't produce a focused enough magnetic field to kind of dig deep into the brain and only affect that region, now the techniques are being modified a bit to affect a region that is part of a circuit that hits a deeper part of the brain,
Right.
like the amygdala, that's more core to the symptomatology of the psychiatric condition.
So the idea would be if you're able to hit part of the circuit that's more superficial, then you could affect the entire circuit, whether that's increasing the connectivity of it or decreasing the
Exactly.
connectivity of it.
Exactly.
Yeah.
And so that is one kind of evolution in the field. And then the other evolutions kind of go further into personalizing the therapy and kind of hint at precision medicine approaches to TMS. And I think the whole kind of field can be summed up into evolving into brain mapping and modulation. And so there's an effort to map the brain, at least in research, map the brain's connectivity profile before TMS is given, identify a region of, let's say, hyperconnectivity or hypoconnectivity that is targetable or accessible on the surface that the magnetic field can actually affect, and then cause therapy or modulation of that region over a sequence of treatment, and then look at how that connectivity that you were trying to target from the surface changes over time, and if that correlates with symptoms, to understand the mechanism underlying the symptom improvement in these different conditions. And maybe it's a very closely approximated region that affects anxiety, and one that's 2 centimeters away on the same side, in the same kind of lateral, dorsolateral prefrontal area, that affects depression symptoms, both in depressive patients, just because not all depression patients are the same. And so that kind of approach is being used now more and more, and having, at least retrospectively, looking at data sets that target one region over another, even in the same general area, that the kind of better targeted regions are having better effects and more specific effects on symptom clusters.
Right. So just to summarize, transcranial magnetic stimulation can either increase connectivity in the brain or decrease connectivity in the brain, and you would determine that based off of specific neural circuit mapping with, in your case, a resting state fMRI.
Yep.
Right. Now, outside of that, is there anything else you want to say? Because I'm going to move on to, does it work or does it not work? And then, tell me some studies that do work. I know there was a alcoholism study where they did TMS in alcoholics, right? If you have a better example, please go ahead.
Yeah. So I think just to kind of carry TMS a few more steps into its current state, it's not just resting state that's used to map the connectome, but you can also use structural forms of connectivity mapping, so diffusion tensor imaging, and even task-based fMRI to locate a region of abnormality, or some region that's not lighting up, or it's lighting up too much for that individual, and target the individualized region of connectivity abnormality or functional kind of activity abnormality, and on an individual subject basis. Even though there's variability across scans and across individuals in these techniques, and they're not generally used in the clinic on an individual basis, this is a gateway for them to be used on an individual basis, because you're just using that scan to target a specific part of the brain, as opposed to the techniques that were used before that, which was to locate based on anatomical landmarks on the surface of the skull. Yeah. And so they would locate a region of the dorsolateral prefrontal cortex using the same technique, but that would miss the mark if you then look at those studies post-scan imaging to see where the TMS should have been, quote unquote, should have been applied. And so using these brain mapping techniques beforehand offers the possibility that you can do more targeted stimulation. And then I'll give you just two more ways that TMS is now being personalized, which is really neat and is applicable to post-concussion. So one is looking at the skull to brain distance and the electromagnetic field that an individual can get from a particular TMS coil. And so if you could map that before or even during TMS administration, you could know that you would have to increase the strength of stimulation, decrease, or slightly modulate the angle that the coil should be held at, just to, even more precisely hit that individual's cortical target.
Right.
And then the final thing is, which I think is most interesting, is the state-dependent effect. And so in TMS kind of clinic, let's say, individuals are told they can do whatever they want. So they might be navigating their phone, they might be watching Netflix, or just kind of thinking or listening to music. And that variability across individuals might account for some of the variability in treatment response, because whatever brain areas or circuits are being kind of activated or used during TMS might actually modulate the effect of TMS. It might be best to have the affected circuit that maybe is mechanistically related to the condition active or engaged or online during TMS, so that you can have the desired effect to that specific circuit. It's one thing if we're using a technique like surgery to ablate a very specific region in the brain that's involved in a tremor. But it's another thing to hit the brain with this TMS, which is fairly blunt and affects kind of a larger part of the cortex, and then has these somewhat unpredictable downstream effects on a circuit that are desired but not easy to predict. And the anatomy of the two regions involved, or multiple regions involved, is so refined, more so than even fMRI can get at, that if you were to engage those regions with a, let's say, kind of a PTSD trigger, where suddenly the fear circuit, is active in that individual, maybe hitting it with TMS during that time frame will enhance the effect of TMS.
That's really, so you bring out that neural circuit so that TMS hits it, right? Or it has a great, I don't know if studies have been done to actually see if that, if that's efficacious, whether bringing out the neural circuit and exacerbating it and then targeting it with TMS, if that's more effective than just baseline. But logically, it would make sense. And then that brings up another point of how this would be used clinically, right? Like, would we be using this in conjunction with with psychotherapy for things like PTSD?
That's a great question. And so that essentially is the way that I'm understanding the field is going, is to not just do TMS in isolation in research and in the clinic, but in conjunction with known and kind of standard therapy. And so the thought would be that, number one, kind of doing it almost synchronously at the same time may cause that kind of engagement of the involved circuit. But number two, kind of doing the therapy in the background, during your TMS treatments can cause kind of a plasticity response where the regions that are being engaged and worked on with therapy and during the TMS kind of stimulation and engagement period will actually have an amplification or synergistic effect. And so I think they are finding in studies that it is effective, and that potentially the state-dependent effects, in other words, what you're doing during the active TMS treatment, mentally, what you're doing mentally, is important at predicting what happens with the region and the circuit and the symptoms. And so knowing that, it may be less important what the actual stimulation pattern is, whether it's supposed to inhibit a region or a circuit or activate a region or a circuit. It may be more important that you bring the intended circuit online during the stimulation. So you're kind of having multiple fail-safes today and multiple ways of being more precise given this somewhat blunt tool.
Do you have a study in mind, off the top of your head, I don't mean to put you on the spot, but a study in mind that really demonstrates the potential of TMS, not necessarily just in concussion, but in any sort of disorder where neural circuitry is either hypo or hyper responsive, hyperconnected, sorry.
Yeah, so maybe I can just kind of answer that by saying the TMS studies in TBI have been, I think, they're in their infancy. There's about under a dozen, and 7 that I know pretty well that have used some form of TMS, usually to the left dorsolateral prefrontal cortex.
Right.
So ostensibly a region that part of a circuit that does get to some deeper structures, but maybe parts of those deeper structures that are not so involved in post-concussive symptoms. It's possible, but maybe it's missing the mark in that way, in terms of what region they're starting with. They have not really done pre-stimulation mapping. And then in some cases, the studies don't involve a sham group, in which the active group gets the real TMS therapy, and the sham group gets the coil placed there.
Just don't turn it on.
Yeah, they
Right.
turn on some sound, or they turn on
Right.
some electrode stimulation of the scalp muscles just to simulate some form of stimulation, but don't actually get the magnetic field propagation. And in some cases, both sides of the dorsolateral prefrontal cortex, left and right, were stimulated, or stimulated and inhibited. So the actual methods varied, the effects varied, and ultimately what they were targeting, like depressive symptoms, anxiety symptoms, headaches, or general post-concussive symptoms. Those are the 4 or 5 things that have been studied, varied across studies. So it's hard to pool the 7 or so studies together and make a conclusion. And there's not really been a ton of brain mapping before or during, and no other objective measures
Right.
throughout, but more just symptom inventories.
Yeah.
And so we don't really know whether in concussion or other forms of TBI, what would happen if you were to be more precise, if you were to hit a region that might be more inherently involved in that condition, or regions that's part of a circuit that's more inherently involved. And you don't know what happens to the circuit over time, because it's just missing data. It's hard to fund a study like that.
Right.
It costs several $100,000 just to pay for all the scanning involved,
Yeah.
let alone the TMS treatments and the compensation for the participants. So it's no fault of the researchers or the field. It's just starting to pick up steam. And I think one of the hurdles they had to get over was that in TMS, one of the risks is seizures. If you're activating the brain and you happen to activate an irritable part of the brain that has been injured with TBI, for example, it can theoretically cause seizures. Although the rates of those in everybody who's performed TMS studies at various parts of the brain are very, very low, and somewhat similar to the increased vulnerability to seizures by taking antidepressants, which is also very low. You still have to think, and funding agencies have to think, is this TBI cohort that you intend to study vulnerable to post-TBI seizures? And if so, is this TMS protocol that you're proposing going to exacerbate that vulnerability?
Right. Well, in concussion, you're not, there's maybe a mild decrease in your seizure threshold, but not nearly as significant as like a more severe TBI, moderate TBI. So.
Right. And the prior studies have been across the board, mostly in concussion, but some in moderate and severe.
Okay.
So, it's reasonable to think that they would be underpowered studies that haven't had a ton of funding to perform all of the bells and whistles of, one could argue it's not necessary to perform all the imaging I'm talking about. But if you wanted to figure out, is TMS targeted to a specific circuit, effective at hitting that circuit in this cohort over sham, and is that amplified by performing some of the personalized protocols I described, where you engage a circuit with a concurrent kind of state-dependent task during TMS stimulation. So a lot of those questions haven't been asked, and so we don't have answers. But
until now,
I haven't performed
until
the
now, you're
studies
asking a lot of questions. But did you get the grant?
Well, so I wrote a couple grants on using TMS to the frontal pole of the brain, kind of the ventromedial prefrontal cortex, targeted towards amygdala hyperconnected regions that kind of may be underlying this fear avoidance behavior. And hopefully by kind of inhibiting the hyperconnectivity with a TMS treatment, that could affect fear avoidance behavior, kind of mitigating it, and relieving some of the post-concussive symptoms in patients who have chronic symptoms after concussion. And so that's the idea behind it. And we have a lot of those imaging checks and balances placed in the study. The study's kind of meant to be a little bit longer than a lot of the studies have been, so that we can look at how symptoms are affected long term. And the kind of precision medicine approach with state-dependent modulation and kind of electromagnetic field modeling and all that stuff to kind of really fine-tune hitting the exact region we want that's personalized to each person is what we're going for. But it ends up being expensive. And the question then is, how do you translate that to clinic?
Right.
You're not going to perform pre-TMS
Can't be doing
imaging.
fMRIs on everybody.
Right. And so we're also concurrently going to measure ECG and potentially, if funding comes through, have them use a wearable device. And so we'll know not only is
Wait. So just to make it clear, we talked about autonomic dysregulation like right at the beginning of this whole session, right? So now what you're doing, you're potentially also tying in the parameters that are abnormal in autonomic dysregulation, like heart rate variability, right?
Yep.
Into your TMS treatment. So can transcranial magnetic stimulation improve autonomic dysregulation, right?
Exactly.
And the objective measures of it, like heart rate variability.
Right.
Sorry, go ahead.
Yeah, no. So in the way that I've been thinking about heart rate variability as kind of an index of the central players involved in controlling autonomic outflow, like the ventromedial prefrontal cortex and amygdala, that circuit is involved in kind of regulating autonomic nervous system, as I was saying before. And so if it's affected in concussion for one reason or another, it may be that heart rate variability would be abnormal, and it would be an index that something centrally is abnormal,
Right.
let alone kind of an instigator and exacerbator of symptoms.
Right.
And so if we can engage the circuit and show that with brain imaging, that we can actually modify the circuit as planned using our technique and modify heart rate variability, kind of increasing variability with the treatment technique, then we could have as a translational idea use heart rate variability in the clinic. So if we give someone one dose of TMS and look at how it affects their heart rate variability, we may know whether they're going to be a responder to this type of treatment or not.
Right.
And we also could, just looking at our study results, identify the region, even though we personalized it to each person's kind of region of hyperconnectivity, we may identify kind of the cluster that was most effective at relieving symptoms, and then say, let's find that coordinate just based on physiological or skull markers in an individual in a clinic without having to do pre-imaging.
Right.
So we may be able to translate the findings from our study to do kind of a way lower cost, more practical
And heart
version.
rate variability and autonomic dysfunction, objective measures of autonomic dysfunction would be a proxy for
the function of this circuit.
Right? So you
exactly.
wouldn't have to be doing fMRIs here and there.
Right.
You would just say, wear this ring, potentially,
Yep.
or measure their heart rate variability, right? Do the TMS. Does their heart rate variability respond or not?
Yep.
It does. Keep doing the TMS. See if their clinical symptoms improve.
Yep, exactly. And then you could follow them out and say, when the heart rate variability takes a dip, is that, and you could kind of study this question as it has been in depression. When the heart rate variability dips, does that indicate they need a booster?
They need another boost. No pun intended. But do they need a booster of TMS? Right. Not of the COVID-19 vaccine. But that's awesome, because then that's sort of more of a dynamic thing where they can just wear it, right? And then, how are you feeling? How are you feeling? On this day when your heart rate variability dipped, or these sets of days. What, doc? I felt crappy. Blah blah blah.
Yeah, and the systems today that the kind of Internet of Things and the mobile applications that are involved with these wearable devices allow some subjective input from the participant who's wearing the device to indicate how they're feeling.
Okay.
And so if they were to sit down and do a little mindful activity and then kind of report their symptoms or their general well-being, and some of the apps are more sophisticated or require more input than others.
Right.
And so we could pull from that, or they could show us that data. And if we make it into a research study, obviously it would be kind of richer data set so that we can understand the correlation between heart rate variability changes, through the course of treatment and beyond with symptoms.
Right. Amazing work. I mean, anything else that you want to add, man? I think that was a great talk. We talked about a lot of different things. I think it's so exciting and amazing what you're doing with TMS, particularly targeting fMRI, these neurocircuitries, autonomic dysregulation, heart rate variability. Awesome talk.
Yeah, thanks, man. No, I think it's a hot area. It needs to be done. We need to take neurological disorders and kind of put them on the TMS chopping block and see what can be done safely. And I think ultimately taking a symptom mapping approach has a really good chance of telling us whether this is an effective approach and whether the mechanism that we think underlies chronic symptoms is actually the case. That's the other thing about TMS, is that you're not just testing it as a therapeutic approach, you're testing the underlying kind of mechanism of brain modulation. And so if you think an area is involved in language and you turn it off with TMS and that person can't speak, it's a pretty good indication that area is involved in language. So if you think that area or circuit's involved in fear avoidance behavior and you modify it in a therapeutic way and fear avoidance behavior improves and thereby post-concussive symptoms, you can pretty clearly say, because you have a sham control, that TMS caused that and fear avoidance behavior is related to post-concussive symptoms.
Right.
And so it is a mechanistic kind of brain-related proof of concept for this link between fear avoidance behavior and post-concussive symptoms.
Yeah.
And then if you kind of apply TMS to other the pain networks and things like that for migraines, it's again kind of getting at that.
So if you increase connectivity in someone that doesn't have any symptoms, could you improve athletic performance, cognitive performance? We're not going to talk about that now. Because is that going to be an upcoming episode on the UCLA BrainSPORT podcast?
That sounds like a good one.
Maybe, maybe not. I don't know. Thanks so much for joining, buddy.
Absolutely.
You're
Pleasure
doing awesome work. So freaking interesting.
Thanks, man.
Yeah. Could keep talking for a while. Listen, folks, that was a great episode. My name's Adel, sports neurologist at the UCLA BrainSPORT program, and it is my pleasure to outro Dr. Kevin Bickart, doing a lot of awesome work with autonomic dysregulation and transcranial magnetic stimulation. If you guys have any comments, anything, you can comment below. And check out more episodes of the UCLA BrainSPORT podcast. Check out down below in the video description. You'll have a link. Click on it. Course through all the episodes. Let us know what you think. There's an email down there where you can email any questions or concerns too. And I think that's pretty much it, buddy.
Appreciate the opportunity.
Yeah, no problem. Thank you.
Thanks.
Bye, guys.